All right, everybody. I am thrilled to have a guest on today's show. Karl Monahan. He is a gentleman that I recently came across his work through a fellow physical therapist's blog. And I said, oh my gosh, I have to have him on as an expert interview. So Karl is going to talk to us today about male pelvic pain, and he has a really interesting perspective in that he treats it and he's also experienced it. And I know that there are several men who have come across my website or my YouTube channel and have expressed some interest in learning more about this topic. So Karl is the one to tell you. So Karl, if you want to just say hi, and then I'm going to read a brief bio. A little shout
Hi,
out.
everyone. I'm
Hello.
Karl Monahan. Nice to be speaking to you, and thank you very much for having me on the show, Brianne, as well.
Yes, I'm thrilled. Yeah, so Karl is a sports and advanced clinical massage therapist with extensive training in abdominal and pelvic health. Such a cool specialty. He has successfully been treating chronic prostatitis and chronic pelvic pain syndrome since 2009, and he is primarily working with male patients. So he currently is also the owner and founder of the Pelvic Pain Clinic in London. So Karl, I would love to really dive into anything else related to your bio, but especially your personal story, especially kind of what got you into this journey and all the details you'd like to share. I'm sure everybody would be interested.
Thank you very much. So as Brianne rightly said, I am the owner of the Pelvic Pain Clinic, and I do have personal experience with pelvic pain myself as well. Does that make me an expert? I'm not sure expert's the right word, but it certainly means I have an empathetic and sympathetic approach to my patients. It means I can relate to them a little bit more, understand what they're going through, and give them personal feedback, but also then base it on the science that's happening around pelvic pain, our understanding of chronic pain at the moment, and how to move forward in treating patients as well. So in my mid-20s, 26, I was leading a very different lifestyle to the one I am at the moment. I was a tennis coach. I was a bit of a party boy. I was living in a boys' house and doing just burning the candle at both ends and in the middle as well, doing an awful lot of stuff. So I could start my weekend on a Friday and it would finish on a Monday. And I had an awful lot of sleep. I had a lot of good fun, but I'm not sure it was particularly healthy or holistic for myself. And at the end of one weekend, I came down with an infection in my testicle, something called Epididymis Orchitis. So that means an infection within the testicle itself, and then the tubes that run around the testicle as well. The testicle started to swell, so this can be a little bit graphic for a second. Testicle swelled to the size of a grapefruit. I went into hospital to A&E, accidents and emergency, and they sent me away on the same day. They said, no, there's nothing wrong with you. It's probably a twisted or a torsion testicle. Look,
There's nothing wrong. There's nothing wrong.
I'm not making this up. 24 hours later, I'm back in hospital and was there for 3 days as well. So once the infection had cleared, then I was just left with a tiny bit of gristle, and that was my testicle. So I only have one testicle now. And actually what happened off the back of that is continued pelvic pain around the area. So discomfort in the perineum, pain on ejaculation, pain on urination, pain above the pubic bone. Here's the interesting thing. Pain in the place where my testicle used to be. Very figure. So there's no tissue there, but I actually had pain in that place. So it does indicate there's more going on with pain than actually just tissue changed itself or tissue damage.
That's like a phantom limb syndrome with the amputees. That's so fascinating. Phantom testicle syndrome. Yeah.
It's a phenomenon we now know exists. I have personal experience with it, but it's also changed the way we deal and approach pain patients as well. So there's so many other things that influence a pain experience, and that's one of them. So for me, losing the testicle really changed my life. I dropped my confidence massively. I avoided relationships. I became very introvert. I've moved from the boys' flat back into my own home with my parents. Gave up my job. Everything really, really changed. I got brushed off from doctors and neurologists. They said, well, you've had a big infection there, so naturally you're going to have some pain and some residue pain there anyway. So I was concerned about my fertility, losing a testicle. I wanted to have sperm tests done, but again, the urologist said, nothing to worry about at the moment. Don't worry about it. It's absolutely fine. You're in your mid-20s, and now I understand that. But at the time, I was freaking out. I had very, very little understanding of what was happening for me. I felt humiliated. I felt mutilated. This is no longer me. I kind of lost part of what makes me a male.
Yeah.
I had very supportive friends and family at the time, and taking one step at a time, I gradually got to build my life back up as well. What was interesting at the time, Brianne, is that we turned back the clock almost 14 years now, and Facebook was only available in 50 colleges in the States. There was no Twitter, there was no YouTube, no smartphone, so you couldn't sit there going through all the information. Google was very, very basic, and the internet was something that you tended to use every now and again. And have you come across the book Headache in the Pelvis before?
Oh yes, I have it right over here. That's a great book. Yeah.
Absolutely.
Yeah.
And it was one of the first book in terms of male pelvic pain. Now, the first edition was released in 2003, which was the same year that I got my pelvic pain. So there was very, very little information. I couldn't do much research around what was happening for me. And I think in some aspects, that kind of helped my recovery as well. I had to just deal with things step by step by step. Go back to basics and kind of build from there. I had none of the other information, which can be very supportive, but also very, very catastrophic in the way we think and the way we respond to other bits of information online as well.
So it's almost like it was, there can be information overload in this day and age, you're saying. Absolutely.
Totally.
Yeah.
Some information's good, but reading about personal experiences can be very supportive, but when personal experiences go wrong, or when you're advised to try something, this worked for me, it might work for you, and you try that one thing and it doesn't work, then again, it just drops you right back down. You hit rock bottom again. You think that things just aren't going well, that no one understands my condition.
Yeah, the power of the mind and the power of other people's words can be huge. So what eventually did work for you, and what did you do that gave you relief?
Yeah, good questions. And so I was very, very fortunate. I was able to move back into my parents' place. I was able to give up my job. The fact that I was able to take myself out of many of my responsibilities meant that I wasn't paying a mortgage. I didn't have bills to pay, which takes the pressure off me then as well. So I changed my diet. I started eating really, really healthily. I became aware that the food we put inside us, the fuel we put inside us, can have a positive effect. But if we're not putting the right fuel in, it can also have a bit of a negative effect as well. So I learned relaxation techniques, meditation, started a yoga practice. I learned not to burn that candle at every which angle I could. And that was a massive learning curve. And it was tough because it meant that I'd remove myself from part of society and my friendship group that meant so much for me. But I knew it was worthwhile.
So it's almost...
Very supportive. Sorry.
Yeah, I was going to say, it's almost like you lost a portion of what gave you a sense of you and your maleness, plus you were losing that sense of identity from burning the candle at both ends. But yet, at the same time, you were developing a new identity with this more holistic perspective. That's really interesting. I mean, you went through an entire lifestyle shift, an entire, 360, really. That's amazing. Yeah.
Totally. And it's very hard to remove yourself from that social environment that means so much for you. Going out and socializing, going clubbing, going and seeing the same friends, going to the same places where you go to all the time as well. You remove that from you, and you're right, you feel like a massive part of you has been left behind.
Yeah.
But in order for me to heal, I had to leave that part of me behind. And I love what you just said there, Brianne, that I had to go 360 in order to almost find myself again.
Yeah.
And find a new me, not my old me. And that took me a while to recalibrate, to feel comfortable with as well, because we want to be that person that we used to be.
Yeah.
Because that person was fun and pain-free and had none of these problems and had 2 testicles. When you move forward, sometimes you always look back. I want to be that person. But in fact, moving forward, we have to be someone new.
Yeah. Well, it sounds like you've developed into an amazing, well-rounded person. And how are you feeling these days? What's the kind of outcome now?
Good question. Yeah, and it's so I still get pelvic pain occasionally, but here's the thing: we get aches and pains all over the body.
Yeah.
Aches and pains are a normal, everyday occurrence, and they're kind of what makes us human beings, in the sense that it means that our nervous system and our brain are working exceptionally well, that things are sometimes a little bit heightened, but the reasons I get pelvic pain, I understand now. So high periods of stress, I know that if I take too much on board, if I exercise too heavy and party too hard. I still like that social side of things. I haven't changed that. But I know to limit it. I know to reduce the dosage. I know to manage things much more effectively now as well. I've been married for 4 years. I've been with my partner, who is now my wife, for 10 years. We have a 3-month-old baby boy. So guess what? My fertility is absolutely fine.
Yeah.
Now, I had a bit of a journey leading up to the point of conception. And I wonder how much of that was contributed by what happened to me 14 years ago. So the journey continues. We continue to learn about ourselves. But I now know that I'm in a more robust position. I know much more about myself, and I can rationalize some of the symptoms that I get because I have experience, because I have perspective on things now as well. Does that make some sense?
Oh, absolutely. I'm loving this. I think, and I'm thinking to myself, this information applies to everybody, male, female, everybody, and so many issues. Pelvic pain, back pain, I mean, just everything. This is wonderful. So I'm very curious about how you've brought your experiences into your work and also what you're doing to treat some of the patients that you see.
Really, really good question. And like I said, because I've had something, it doesn't mean that I'm an expert. So I don't just put my own personal spin on things and say, well, this worked for me, because I think that's dangerous as well. I think it implies that I know, because I've had something, it means I'm all-knowing, I'm omnipotent. That's really dangerous. So I take my experiences. I've done an awful lot of education. I've studied pretty hard to get to where I am now as well. And what we understand around pain is that it takes a multidisciplinary approach. Easy for me to say. It takes a multidisciplinary approach. It means that maybe I'm not the complete answer. Maybe I have to refer to a psychologist. Maybe I have to refer to a CBT therapist or a cognitive hypnotherapist or an acupuncturist or a nutritionist or a biomechanist. There are other modalities, and it's really important when you're treating a patient to treat that patient, to unlock their individual lock with the right set of keys. And that can take a little bit of time. So instead of using an off-the-shelf cookie-cutter approach that applies to everyone, we gain information from the individual. We ask them what's really important for them. We look at things like meaningful activity for that individual, and we get them back to meaningful activities. And that might be for someone, it might be for someone that I want to go and sit down for 2 hours and enjoy a film with my partner. It's something that patients who don't have pelvic pain just take for granted. So we have to really dissect each individual, look at their beliefs. And the thing with beliefs and attitudes and understandings around pain is that they have massive implications. One of the reasons we get chronic and ongoing pain is that when we have more questions around what's happening and less answers, that's when our nervous system and our brain remain on a heightened state of awareness and a heightened sensitivity. And that means that a sensation that might cause us an awareness or a discomfort for someone with chronic pelvic pain causes extreme pain. And maybe not just in that moment, but actually pain that lasts for a couple of hours, a couple of days, a couple of weeks. So looking at the individual, looking at their set of circumstances, seeing where they are in their own society, and that might be the family unit, it might be within their group of friends, it might be with their situation within work. How much does my pain presentation, how much does my symptoms affect that side of me? How much does my symptoms affect my overall mental health and my mental capabilities of dealing with things as well? And then what am I able to do physically? So how much activity, how much exercise am I able to do? And if I can't do exercise, if I can't do activity, then that will have a knock-on effect on my pain and my pain response, and also my robustness as well. So I get patients whose pain can escalate from a few activities that cause them pain to almost everything that causes them pain. Ice cream now causes me pain. If I look a certain way or I twist a certain way, that causes me pain as well. And that's a real shame, because that patient just starts to shut down.
Yeah.
They do less and less and less. They get something called fear avoidance. And this is really well documented now, that you avoid activity in the fear of making something worse and the fear of making your own situation worse. I get patients who now, they don't drink coffee or alcohol, or not that I'm advocating those things, but, or eat spicy food, or even eat ketchup, because they found that ketchup once was possibly linked to their symptoms.
Yeah.
And now that they've given up ketchup, well, they've given up mayonnaise because they think ketchup and mayonnaise are quite similar. They're a sauce, they're something I put on my food. And you see that people end up a shell of their former selves. It's really, really sad to see, but it means we need to look at the individual.
I love this. So much of what you do is really listening and really looking at the individual patient, and then seeing perhaps, CNS upregulation, central nervous system upregulation is, I believe, what we're really speaking about, when everything just becomes quite heightened. And it sounds like you really need to look at each individual person to see what is kind of triggering for them. And how would you recommend, if somebody was listening to this right now and thinking, this sounds like me, is there something that you would recommend for them to do on their own, maybe at home, to start thinking about what could be their triggers, or what, how they might start going about treatment with themselves?
That's a really good question, and thank you for asking, Brianne. There's something. So Noi Group are David Butler, Laura Mosley.
Yeah.
They're two of the leading world pain experts at the moment. Australian guys. Take a look on YouTube. They've got some really good videos. They're good fun. They're really humorous, and they really relate to the individual as well. It's not high, heavy, hard science.
I'll put a link to them too, because I love the Noi Group has wonderful stuff. So I'll put a link to that as well. So video description.
Perfect.
Yeah.
Thank you. They do something called DIMS and SIMS. So DIMS are danger signals, SIMS are safety signals. And danger signals ramp up our pain. They're things that we find that provoke our pain and make us feel anxious around our pain, and raise questions that we don't have clear answers for. And they're individual for people, but I'm going to give you some examples in a second. And safety signals are things that dampen down our pain, that provide us with relief, that make us feel more comfortable, and can deal with our pain as well. There's an article on my website called The DIMS and SIMS of Pelvic Pain. And to begin with, one of the activities I get with my patients to do before they see me face to face is to make their own list of danger signals and safety signals. And that gives me a real clear window into their belief system. And it gives me a clear window into how we can change their beliefs. And when the list of DIMS, danger signals, outweighs the list of SIMS, safety signals, then the brain and the nervous system will remain in a heightened state of alert and awareness, and the chance of you experiencing a pain response are much, much higher. So what we need to do is we need to change some of those DIMS into SIMS. So change the danger signals into safety signals. And when we've got a long list of safety signals, then the patient feels relaxed, they feel calm and confident, they feel much, much more in control. Mm-hmm. So some of those DIMS for patients, some of the common ones are certainly for pelvic pain. I'm sure this isn't just for men, I'm sure this is also for females as well. Sex, sitting down for long periods of time, not enough sleep, alcohol, so something, burning the candle at both ends, that might be. So maybe socializing too heavily, or doing things at too high a dosage, exercising too heavily. So they're things that will often provoke pain and make patients feel more threatened, or like their systems are very responsive. Some of the safety signs might be talking to someone about my symptoms, finding a professional who's willing to listen to me and offer a bespoke program. So they're things that make the patient feel more comfortable and more confident. Having a really good laugh with my friends. So safe environments, doing something that's really, really enjoyable, and changing in endorphins, changing in that threat response, changing in that catastrophic thinking. It might be getting a good night's sleep. They're often safety signs, things that will dampen down pain. So to begin with, I would advise looking at DIMS and SIMS, looking at things that provoke and make my pain worse, mm-hmm. and looking at things that make my pain better, and seeing if we can make some of those DIMS into SIMS. So is it that sitting down is actually really, really painful all the time, or is it only in certain situations? Is it the chair that we sit in? Is it the length of time that we sit in as well? And once we've reframed some of these thought processes, then they become less threatening for us. Mm. They become a bit more of a safety sign. So it could be that, well, sitting on a hard chair for hours and hours on end is actually a danger sign for me. But it would also be for a danger sign for someone who doesn't have chronic pelvic pain.
Yeah.
And that's important to realize. So a lot of these responses are really, really normal. Whereas sitting on a sofa, watching your favorite film with your pet dog or pet cat or hamster or rabbit or whatever it might be with the loved one is a safety sign. It's still sitting, but it's looking at it, changing our viewpoints on things, looking at things through different glasses. Does that make some sense?
Yeah, that absolutely does. Yeah, and I love the way you're kind of normalizing so much of this. That's really a neat perspective. It's like, because I think people can get into a spiral where, it's a pain spiral, and then that just makes them more tense, and that makes them more painful, and it makes them more inward. The fear avoidance thing, like you were saying, they don't want to do anything that might make it worse. But so much of it is just it's this spiral. And you're sort of saying, let's see how we can break this, look and see what we can fix right now that is a fear, a dim, and turn it into a sim, so we can start there, just kind of start chunking away at this and normalizing it and saying it's okay, and then working up from there. I think that's really neat. I've never really actually seen this perspective I hadn't thought about this as being such a significant perspective of your treatment. I thought I was expecting you to tell me that you were mostly doing hands-on massage and techniques like that, but it sounds like this is a really big piece, a starting piece of your work.
Yeah, and so my practice has changed over the years as well, with my understanding around what pain is and what provokes pain as well. And I might do some manual therapy with people. That's certainly a huge part of my background. That's what I've been doing for 16 years now. And so I don't dismiss that, but I also am aware that certain techniques are more relevant for certain people. So for some patients, actually massage and manual therapy is enough to cause a pain response anyway.
Yeah.
Some people don't like massages. So if some people don't like massages and it makes them painful, well, by giving that person a massage, even if it's really, really light and gentle, it's going to be a dim for them. And if it provokes pain, then it sets up that guarding process. And the more we get that patient to guard, then the less likely are we to get them to recover. Guarding is a really, really important thing. And what you mentioned is that when we guard, because we feel we're going to get a pain response or something's going to cause us pain, is that we tend to shut down. We do less and less and less.
Yeah.
We have less confidence. We move less. And actually, we know that movement creates less of a threat in the body.
Yeah.
We know that with graded exposure to movement and the right kind of movement, it can create calm and confidence and a sense of robustness and a change in the sense of this fragility that we often perceive that chronic pain patients have, or a sense of that the patient themselves feel so fragile and so delicate they can't do any of these things. Whereas getting them back to some of these meaningful activities gives them confidence, it gives them purpose, it gives them back some of their life. And this sounds so simple, but those are what gets the patient through. And I get a really, really positive response from many of my patients because I'm giving them back their life again.
Oh, I love that. I would love to, I'm going to put you on the spot here, and I'd love if you could briefly share a kind of maybe a success story, maybe a story that stands out in your mind. And then perhaps you can give us your information about how people could find you and connect with you.
Sure. Yeah, no problems at all. Yeah, no pressure. Thanks very much.
Good. I know, on the spot, but give us your best story.
So let's talk about sitting. And sitting is one of the key things that pelvic pain patients really do struggle with. Male, female, children. Sitting is a functional activity. And what I mean by that is there's no reason why we shouldn't be able to sit. We spend a lot of time sitting here in the West, and we spend a lot of time sitting here in the West on chairs. And I have a bit of a theory that maybe in some of the Far Eastern cultures, maybe where they squat or they sit a little bit better on their knees in a kneeling position, that perineum isn't an area that gets really aggravated really, really quickly. Yeah. We don't tend to do that here. So sitting is a very emotive thing for patients. And when a patient can't sit for any length of time, it affects not only their work life, especially if they're desk bound, maybe their commute to and from work, and their home life as well. And once we've poked that bear, once that bear's angry and they have a pain response, it's very difficult to dampen down and soothe and calm and stroke that bear.
Yeah.
So I've got patients, and there's one particular patient, and so a high-end professor spends a lot of time researching, spends a lot of time sitting in conferences, and spends a lot of time having to fly places as well. So they might be flying to the States, they might be flying to Europe, they might be flying a little bit further and beyond. And to begin with, they'd avoid doing things like that. They simply wouldn't go and do those activities. And sitting down at meetings would just become such a dim and such a no-no that it really started to affect their professional career and their own personal outlook on themselves. And when that's the case, when you can't see beyond what's happening in front of you, it becomes really, really desperate sometimes. So we digress to a mean. We make them comfortable in their situation. So if sitting on a hard chair isn't productive, then how can we dampen that down for you? How can we make that more comfortable? So a prostate cushion, and using the prostate cushion or any kind of cushion alleviates some of the pressure on the perineum. Means that the bears poke less, and those already sensitized nerves become less sensitive because the pressure that's being applied to them, the nerves that respond to pressure are mechanoreceptors, and the mechanoreceptors in and around our sit bones, our perineum, our glutes, our buttock muscles, it becomes very, very sensitive. So over a period of time, we got him to use his cushion less and less, and we did something called graded exposure with him. Yeah. And this is choosing a seat or a scenario or a situation, sitting in this particular case, that is painful, but getting that patient to sit at a dosage that's well beneath their pain response or that point of pain provocation, and I mean well below. So we started off, and I start off with some of my patients at seconds, 15, 30 seconds, a few minutes. And gradually each day you expose that patient to sitting in that particular position for a slightly longer period of time. And what that does is that it teaches the nervous system that this isn't a threat, that sitting actually isn't a threatening thing. A chair isn't a damaging piece of equipment, much in the same way that a knife or a gun isn't damaging or harmful until we interact with it. Does that make some sense?
Absolutely. This is wonderful. I'm loving this. I'm getting treatment ideas too for my future self if I, ever need to have this. It's now in my toolbox. So thank you. Continue, please.
Practical application.
Yeah.
And over a period of time, we get the patient to sit for a longer and longer period of time. Yeah. And then we start to remove the cushion. So the patient is now sitting without the cushion in a chair that they would have once seen as being a torture device, but is now something that they can sit at with relative ease. And that process continues and continues. And there might be the odd flare-up. And when that happens, we drop them back a few days and we start the process again at a comfortable duration. Now, this particular patient I'm talking about, he now flies to the States. He will now fly to the States and he'll go and sit in a 3-week conference. He's not sitting for 3 weeks. That's a very long time to be sitting. But he's at a conference for 3 weeks in which he might be sat for a number of hours. Yeah. And he now doesn't look at a chair and think, crap, this really isn't going to work for me. Yeah. He now sees it as an opportunity and less of a dim and more of a sim. And yes, there are the more appropriate chairs and less appropriate chairs, but he's now even considering flying to so he lives in the UK. He's now even considering flying to Australia to see his family over there. Wow. Something that he wouldn't have even considered, a year or so ago. So it's possible to get patients back to meaningful activity and functional activity through graded exposure with a bespoke program that's individualized to the patient and give them back some of their life again.
Oh, that is a wonderful, wonderful story. And for somebody who's not dealt with pelvic pain or worked with people who've dealt with pelvic pain, they probably wouldn't understand that chairs can be seen as threatening. But it's true. I mean, absolutely. It's very meaningful, very individualized to the patient, and something that probably if somebody is still watching, they probably are saying, yes, I understand this. This makes sense to me. And what is it in my life that may be that monster in my life that I'm not even really realizing could be tamped down to a level where I can learn to deal with it. I love the graded exposure. I think that's wonderful. And I love that story of the professor. I'm so glad he's better. Yeah, that's amazing. Where could people find you if they wanted to connect with you and learn more? And if they live in London, maybe come see you.
Yeah, good question. So I have patients come across Europe, and the UK to see me in London, and I do Skype consults with patients across the world as well. Obviously, I can't do the physical assessments, but we can go through graded exposure and things like that with them as well. So I have my website, thepelvicpainclinic.co.uk. There's a number of articles and DIMS and SIMS is also on there as well, but some good background research into why pain occurs, why chronic pelvic pain occurs as well. I have a Facebook page, and again, does exactly what it says on the tin. It is the Pelvic Pain Clinic. My Twitter is called @ProstatitisHelp.
Okay, I'm writing all this down.
Perfect.
Okay.
And people can also email me, and it's info@thepelvicpainclinic.co.uk as well.
Okay, wonderful. I will write all of these notes in the notes of the video description below. All the links will be there, and I am just so appreciative that you took the time, Karl, to come on my show today and teach us all a little bit more about pelvic pain. And again, this really does apply to everybody, not just males, but I'm very grateful that you shared your personal journey too. So thank you very much. And we will be in touch again soon. Karl actually is an expert in a massage technique called abdominal massage, so we're going to hopefully talk more about that, and maybe I'll have another interview coming up about more of the manual therapy stuff that we can discuss as well. So thank you so much again, and see you later, everybody. Bye.
Okay, thanks. Bye-bye.
Bye.